some people who come in and like, well, I've got a bronchiectasis, I've got autoimmune, which is thymus is T3, and I've got a frozen shoulder, and I've got mid-back pain. And it's all the same segment, driven by this trapped inflammation.
This is Good Outcomes with Dr. Dave. Welcome to our Clinicians Corner segment, where I reveal how we get good outcomes in our successful PT practice. And I'm your host, Dr. Dave. Let's get started. Mr. Tuckey, the originator of Fascial Counterstrain, began training at the Jones Institute in 1992 under Dr. Lawrence Jones. He was one of only 4 physical therapists certified to teach strain counterstrain, which is the sort of the precursor to fascial counterstrain back in the 90s. He has gone through multiple levels of different manipulative trainings over the years, going back to Michigan State, and then going on through many different types of manual therapy. Very similar to what I did before fascial counterstrain. As of about 2018, Brian has been able to develop approximately 1,200 fascial counterstrain techniques, which were essentially birthed out of the original strain counterstrain that he was originally trained in by Dr. Lawrence Jones, the osteopathic physician that originally came up with this back in the 1950s. This is not necessarily even new, but it does have a new spin, and Brian has advanced it so far since its humble beginnings with Dr. Jones. It is being taught not just locally here in Pensacola, but also globally around the world. A larger growing practitioners are coming into the fold because of how powerful this technique is.
Thank you, Dave, for giving me the opportunity to talk about what has turned out to be my life's work at this point. Looking back into the 1991, 1992, when I first took a class from Dr. Jones himself. We're looking at upwards of 35 years of experience. I was speed dating manual therapy classes when I graduated and was disillusioned by the results, or the outcomes, as your podcast is called. And, carryover pain. It was back in the days of ACL reconstructions where they were still casting people. We would bring in some of these ACLs who had been casted for 6 weeks, bent at 30 degrees, and essentially sit on their knees while they're screaming at night. That was kind of the world I entered. No pain, no gain. Everything was scar tissue, forced through it. Doctors would sometimes gauge the quality of the therapist by how much pain they reported when they got back. It was a weird world that I never really felt that I fit into, because the techniques were saying you should be able to blast through these barriers, and it just didn't work. If you did manipulate a joint on Monday, it was just as stuck as you saw before on Wednesday. There was this disconnect, and I was searching for answers until I did meet Dr. Jones.
You really hit the nail on the head with that. If I was ever honest with myself, I knew that although symptoms were changed, that joint was still stiff. I knew that first rib was still high. And I'm like, I don't understand. Like, they feel better. That's great. That's kind of what we're going for. But there was always something missing. And this actually brings us to my journey. I've been a physical therapist for 15 years now, but up until when I was introduced to Fascial Counterstrain, I was a PT for 12 years. I went through all the same Paris classes that you probably went through, Maitland and McKenzie. I've taken a very eclectic, similar to yourself, process of what we'd consider direct treatment. And I got really great outcomes. I did really well with that. In fact, I now have a self-pay physical therapy practice in Florida. And it was built on those principles. A lot of PT practices nowadays are mostly exercise-based. And so even the direct manual techniques that you and I were brought up on work really well for a subset of clients that don't get relief from a traditional exercise model. Here's my testimony. I didn't need counterstrain. If I wanted to look back and be honest, I don't need counterstrain. I had a successful practice. I was growing rapidly. I don't need to do that. However, I think this is where the rubber meets the road. When I took the initial Fascial Counterstrain Foundations course, I had a bit of a midlife crisis. I got emotional. My colleague, Isaiah, you know him well, got to see me emotionally go through this process of, here's what I know, here's what I saw, the science makes sense, but then I'm not used to this. And then I go through the class and I practice some of the techniques, and then it works. And I'm like, wow, that tight hamstring went away. And that's actually a palpable change. I had to process that for a couple days after the class. I'm sure you hear this a lot from your students, that after we go through this class, there's a radical shift. What I had to do is process that But once I had processed that, I got to the point where I'm like, this is the thing that I've been looking for, the piece of the puzzle that I was missing, and I couldn't deny it. Once I emotionally got myself together, I was like, I'm sold. I bought all your packages. I bought every class for the following year. I don't know if I recommend that for normal people. I'm a crazy person. And I was like, I can't not know this. And what was interesting and very obvious to me was that the power of Fascial Counterstrain is not the 2 classes that you took, but knowing the breadth of the work first.
Good.
Yeah, you grow, but it becomes more powerful as you work through the curriculum. Now, don't get me wrong. I think that you probably did this on purpose. That initial foundations class has some of the most powerful techniques in the class, most commonly found, and so brilliantly done. At the same time, as you work through the class curriculum, you realize, oh, this relates to that, and it builds on itself to the point where now, talking about outcomes, I rarely use my old manual direct techniques anymore. And so my first question to you, how many people have that kind of experience that I had with your class?
So there's 3 different sets of people, but the 2 most common are people who experience the work in their own bodies.
Mm-hmm.
So that's a very common group where a practitioner with chronic unresponsive symptoms saw a fascial counterstrain practitioner a visit or 2, and they're like, okay, how'd you do that? It went away, and I got to learn this. So that's a large group. It's grassroots. There are also the group where a chiropractor or another therapist starts to co-treat because they're treating someone you're treating, and they see the rapid objective change and subjective change, functional change in somebody they were working with. So they're like, what did you have done? At one point, I had a guy in town when I first started in Frederick, Maryland. I didn't know he was there, but he was a reflexologist. He called me up one day and they said, Dr. such and such, I want to use his name. He was a doctor of acupuncture and something else. But anyway, he was a reflexologist and professor. So he calls me up and he says, I cannot tell when anyone in town sees anybody, but when they're at your clinic, I can tell. What are you doing? And then there are people that might just be looking for something, heard about it, and could come into a forum like this and watch a podcast and say, wow, that matches my experience. That makes a lot of sense with what I've seen in the clinic. Basically give it a look because they're looking for answers, as you and I were at one point in our career. As you said, you didn't need it in the sense that you found a population of patients that you could fill your practice up and you would make improvement. But if I put myself back in that day, I improved a lot of people. But I don't know how many I really did cure. When you start to use this multi-system indirect manipulation paradigm, the scope of the work goes much beyond pain and much beyond the musculoskeletal. Your practice rapidly expands. I had one person today that I saw for pain all day, just one. So they were all neurological things, imbalance and digestion, sleep disorders and anxiety. I saw one pain person today. So when you can treat the neurology and you can treat the viscera and you can treat the vascular supply and the musculoskeletal, your practice expands naturally. But then also, can you get that orthopedic patient not to 70% with a continued home program, but pain-free without a home program? Did you truly get rid of it?
You stole my thunder because the end of my testimony is I did need it because I was never satisfied, right?
Yeah.
That was the thrust behind it all. Is like one of the reasons why my colleague Sarah and I were looking into the research that actually found your article. We were one of the weird people maybe that found your article and said, this is it, and then took the class. It was one of those things where after we read it, we're like, okay, this makes sense. Let's look into this because we're finding these problems in clients. We did need it, but we didn't need it to fill the practice. We could be financially successful, but is that really what our heart is? Is that really what we want? This speaks to all the clinicians out there that are listening to this. Do you want to be just okay? You can fill a practice with okay.
Sure.
And you can actually fill a practice with being great, good. Can you be excellent? I think Fascial Counterstrain gives us that avenue to be truly excellent, addressing things not just from a root cause level, but a multi-system level, expanding not just the musculoskeletal system, but getting into the visceral and neurologic systems and everything else. Now, all of a sudden, not only is our scope more broad, which is always good, but then also the depth in which we can help someone, it's just so much deeper.
Yes.
That's what a good outcome is, right?
So thinking back when I was using an orthopedic direct or even orthopedic pure paradigm, patients would come in and they might say, I've got anxiety, I've got sleep issues, I've got a bladder problem, I've got edema in my foot, and I've got a shoulder problem. I'm like, okay, I'm your shoulder guy. So I would exclude every other system. And I was like, well, I don't know what to do about any of that, but I can help you with your shoulder. Now we're basically like looking down the list, like, yeah, I think I have an idea for all of those things. When you start to get into the central nervous system brainstem, you can start to say, actually, there's one area of the brainstem that could do all those things.
And again, I'm 3 years into this now. And so it doesn't feel like it's been that long. My body maybe feels like it is. But I will say that the way that I think of common denominators has shifted quite a bit. It used to be pelvis and foot. Okay, they're connected, or shoulder and thoracic spine, they're connected. And common denominators, okay, fine. But then all of a sudden we start thinking about multi-systems where like, okay, all of these things can be solved by maybe an autonomic treatment, right? The common denominators become more robust because it gives us more data, which is really helpful to integrate what we're hearing from our clients. Pulling that information out is so helpful. We've talked about our experience and how excited we are. Brian, in short, let's just, for our viewers, let's describe what fascial counterstrain is.
It is a complex process that identifies and removes trapped inflammation from the body. That's the simple definition. Where the discussion gets lengthy is, how do you identify where that trapped inflammation is? And what does inflammation do to the body? And then you have to understand that it is an indirect form of osteopathic manipulation versus direct. By definition, direct techniques, you identify a barrier and you attempt to force through it. Indirect, you disengage, unload, decompress, going in the direction of ease. You'll see there, it's basically a inflammatory drainage paradigm, uses decompression, and it is inherently getting to the root cause of the problems and is wonderfully painless. You can use it on elderly, you can use it on babies. It does not produce pain. I was just never somebody that can inflict pain on somebody. It's just not in my nature to do that to somebody who's already in pain. So I was always like, there's got to be a more elegant way to get to the root of these problems than just blast through it every night. And that's really what indirect techniques are. The osteopaths develop them. They take a higher level of tactile sensitivity, a higher level of training, but they're really almost magical in their result, particularly in the world of carryover. Where is that inflammation trapped? How does it get there? What does it do? That's kind of the first things I'll talk to patients about.
I get these questions all the time. It's like, so you can identify where there's trapped inflammation and you flush it out. Like, what do you mean by flushing it out?
Let's preface this by saying, anyone out there who is a practitioner, this entire history, method, the physiology behind it, the anatomical correlation of the tender points we'll talk about, and a case study that is video followed was published. It's entitled Fascial Counterstrain, a Methodological Advancement in Indirect Osteopathic Manipulation. We'll have a link for it. And it was published in the International Journal of Osteopathic Medicine last month, so December 2025. This was one of the bucket list things that we had to do. The article that you were referring to was the trapped inflammation in the body. Do we know it's there? And how did it get there? And what produces it? That impaired lymphatic stasis paper will also link for you, but that's on the what is the problem? And the method paper is what is the technique that fixes it? So right now, at this time of 2025, 2026, both those things are peer-reviewed and published. So you can say, all right, I want to know more about that inflammation thing, how it drives all these reflex arcs. You can read that. It's 143 citations and 6,300 words. And in the Frontier Journal, that article's been very well received. It has almost 30 citations. It has 60,000 downloads and reads, which is double any article in that journal all time. And just to give you an idea of citations, your average article in the Journal of American Physical Therapy has like 2.3 citations. So it has 30 already. Most of them were more recent this year because people are reading this in many fields and they're saying, you know what, this inflammation thing, this makes a lot of sense. I'm going to say things that are anecdotal and use analogies and simplify for the audience, but there's real science behind this. Essentially, the clear fluid of our body, the lymphatic fluid, is picked up by these pre-lymphatic channels. And eventually that goes into your lymphatics and it goes into your venous system and eventually out through kidneys process. Turns out cytokines, which everyone remembers from COVID, cytokine storms and things, those are inflammatory proteins, pro-inflammatory cytokines, that can cause pain because they stimulate pain receptors chemically. So if there's a bunch of cytokines trapped in that clear interstitial fluid, you can get chronic pain generated from that tissue. So that's number one. Number two, that same inflammation triggers the fascia in the connective tissue. Okay. The fibroblasts, through a mechanism, produce another chemical. It's called TGF beta 1 that makes the connective tissue contract. So you get the cytokine in there from a trauma or from a virus or a surgery or an infection. It triggers the release of another chemical from those fibroblasts. It's the fascia tissue. And then it contracts. So it compartmentalizes and traps the inflammation in the clear fluid. So those are what creates the tender point, okay? But those pain receptors then take that message into the spinal cord, and things happen besides just pain. And this is where clinicians will realize there's segmental motion restriction. You go down someone's spine, and you're like, okay, that person with carpal tunnel is also stuck at cervical 5, cervical 6, where that nerve comes out. Or you're going down their back, and you're like, oh, you're stuck right here between that T4 or T5. That could be the level where that person has chronic medioscapular pain, or they may have chronic cardiac symptoms, problems with their heart. And so you see these guarding reflexes. Those cytokines stimulate the pain receptors. That nerve impulse goes into the spinal cord and triggers what's called a muscle guarding reflex. So all trapped inflammation not only creates a tender point, it creates a muscle guarding reflex. So what happens if you're muscle trained, orthopedically trained, is you're picking up on these muscle guarding reflexes and saying, okay, I'm just going to pop that joint, or I'm going to stretch that muscle, not realizing that it is part of a protective reflex driven by these trapped cytokines. Those same cytokines do more, though. That's an afferent sensory nociceptive neuron that carries that message in, goes into the ventral horn, which is the muscle guarding reflex area, but it also goes into the autonomic intermediolateral column of the cord. Basically, it messes up vessels and organ function, smooth muscle. So you can get artery vasoconstriction. You can get the veins to constrict, which could cause swelling and edema. The arteries gives you weakness. It could give you atrophy. And then it also goes in, messes up that sympathetic neuron, which can impact not only vessel function, but organ function. So now, from one area of trapped inflammation going into that area of the spine, all of the structures at that level can all be impacted. Muscles can spasm, sensory neurons are firing, it's tender, the autonomic nervous system, which messes with vessels and organs, all dysfunction. So a person with like a T3 problem could have problems with their lungs, because that's a 3 muscle, could have problems with the arteries into their arms, and it could also have upper back pain, okay? Could also feed into the capsule of the shoulder. So some people who come in and like, well, you know, I've got a bronchiectasis, I've got autoimmune, which is thymus is T3, and I've got a frozen shoulder, and I've got mid-back pain, and it's all the same segment, driven by this trapped inflammation.
So that's a mouthful for a lot of, I'm sure you don't say that to your clients on the table. You're obviously speaking to the clinicians here. So
Yes.
Let's take a step back and say,
So
okay,
I was talking to you.
what does
Okay.
this look like? Yeah. So what's this look like? Mr. Tuckey, like my back hurts and you barely touched me and it's better. You said you drained inflammation. Like, where did it go? Or, obviously we understand now there's some muscle guarding reflexes. How would you explain it to your patient in 30 seconds, in a more simplest manner?
Typically, they've already had either something that's chronic or an unresponsive case. So we can say, when you go and get X technique and they work on your muscles, you feel better for a while. They'll say, yeah, I actually feel better for a couple of days, right? But then that is coming back. What we have found, and the research supports this, is that there's an area of trapped fluid and inflammation that's driving the whole reflex. And the muscle thing is secondary. So what I'm going to do is use an evaluation process, which includes tender points, to find out where this is. And what we're going to do is I'm going to go ahead and drain that, and then we'll go back to that muscle you've been working on, Okay. Or use something's called touch inhibition. Through the proprioceptors, you can push on that area of the tender point and it will disable the whole spinal restriction. So you could say, feel this tightness in your spine, and I push on the tender point and it disappears. So I'm like, that's the body's way of saying that is related to that. And people feel this stuff. And I'll say, so now, has anyone ever gone to the area of your triangular ligament of your liver, where this tender point is, and done a release on that structure for your mid-back pain? Well, no. I'm like, right, this is the source. You'll see we'll come back. I'll be down here working at what I've diagnosed as the source, but you'll see these other things instantaneously change. Okay. So it's just no one's found the source yet. People are treating the symptom. Just they don't understand muscle guarding reflexes.
And I think that's where I go with my explanation, is that obviously you've had these things done before, whether it's exercise makes me hurt, or I've had a manipulation, I've had some soft tissue work and they didn't help. I'm like, okay, well, that's probably not the correction. There are times where that is all you need. And
it can work.
But when you get to the point where it's been 5-10 years and you've had the same massage therapist poking on the same muscle to get you going, maybe you can consider the fact that that's not the source and it's maybe a secondary symptom of a problem somewhere else. I want to credit you, and you can correct me. I think you once said in one of your classes that pain's a liar.
Oh, yeah.
Where you have pain is not always really where the source is.
For sure.
And I think when we look at the direct model, that statement that pain being a liar flips that model on its head. When I'm like, oh, you have pain at that CT junction in the middle base of your neck, where that shoulder meets the neck, everyone has pain there a lot of times. You're like, well, that's the problem area. What we've found in counterstrain world, that's a really important segment where a lot of things report to. That can get locked up from a number of things all over the body. People are like, but I have pain here. I'm like, what does it look like to find where it's coming from? When we say that pain's a liar, now we start to understand why we have a chronic pain epidemic in the United States, is people are chasing pain instead of underlining dysfunction.
Probably the most example of pain is phantom limb pain. Phantom limb pain, for anyone in the audience doesn't know what that is, these are people who had the extremity amputated and have foot pain. So they're like, my foot hurts and I don't have one. It can be that much of a projection. And it has to do with some issues that pain message is carried through the spinal cord all the way up to the processing center in the brain. So pain is a very complex issue, basically simply as to where it is perceived in the brain. We're looking for the driver, not where it's perceived. That's the key thing.
So what we're doing in counterstrain world here is we're able to identify where there's trapped inflammation in your body. That inflammation causes a whole bunch of problems that you feel as symptoms, whether it's a numbness, a tingling, a weakness, pain, a sharp or dull. And when that inflammation is trapped, it creates those problems. You feel it. You come to us and we say, hey, we can drain it. We drain it by gentle fascial glides or positional releases that are ultimately in a direction of ease. So if it hurts when you go one way, we just take you the other way in some fashion, and then it drains out. Where does it go? And then what is the result of that technique after we drain out the inflammation?
Yeah, and that's where it gets into the lymphatic system science. Okay, so it is going from these pre-lymphatic channels. When we put a little bit of a stretch on the lymphatic vessel and create a vacuum in the area of the stasis. And it turns out when you put a stretch on a lymphatic vessel, it actually pumps. And then we unload that area and it kind of just creates a vacuum and it just sucks it right out. And the beauty of it is when you unload that tissue, you're decompressing the pain receptors and again, that chemical starts to drop and the pain just settles. And people will often say, wow, that position feels good. That glide feels good. It's not something that you feel like, hey, this person's taking me into a danger place. And it's often positions that people have kind of approximated themselves. Like, I kind of sleep like that. I got to be here because when I go here, it hurts. And we're like, yeah, we're going to be taking you into that direction just very precisely.
And that's great that you bring that up, because that's how Dr. Lawrence Jones discovered this technique to begin with, was a patient that he just couldn't figure out what's going on. And one day he's like, hey, go get comfortable in a position. And he left and came back, and his patient just...
He took a guy who had extreme back pain attempting to stand, who had been treated for 12 weeks by 2 different chiropractors. He treated him for 5 weeks for his stuck L2, flexed L2. And the guy was literally bent over. And he said to Dr. Jones, because I used to teach for Jones, he would tell his story. And he basically said, if I could sleep, I might heal, but I can't sleep. So Jones said, let's just experiment. And with him, ended up finding this really, really flexed position, knees off to one side. And the guy's like, pain just stopped. So he propped him there and left him there for 20 minutes just to see if he could sleep like that. And then he would tell a story. When he came back, he was like, do you have it memorized? He's like, yeah, I got it. Been here 20 minutes. Still feels good. And he ended up standing up perfectly straight with no pain. And then Jones assessed that joint and that L2 restriction was gone. So just that concept of, wow, somehow that position fixed that really rigid facet problem with no trauma. That's what started the whole. Now, did he have any idea of the physiology you and I are touching on? None whatsoever. Okay. So, when Jones was mapping out his surface tender points in the positions that would fix them, he often would just name what joint would also free up. And he would give us signs and symptoms, and he would say, that's an anterior L2, because it was a front side tender point that helped L2. So he understood this segmental connection of these muscle guarding reflexes. And, when people are like, I get the question, how in the heck did you take it from that to this? And I have to, in part credit the modern science and the internet. I can literally scan the world for the latest lymphatic, pain science, connective tissue science in my pajamas at 11 o'clock at night using the internet. Back in his days, he would have to go to the Library of Congress with the Dewey Decimal System to look something up. So you never did, even if it was there.
I think this is his ability. What kind of doctor does that? He's like, hey, let's experiment. Let's just get you in a good position. I think what a credit to his character, and as good of a clinician he was, I obviously never knew him. I was in grade school when he passed away. The reality is, I said, there's something to this. I'm going to explore it. I think that's what we want in our physicians, our PTs, our chiropractors, our medical providers. We want people to be thinking about what are we doing and why all the time. I feel like that's something we've lost in the medical system, the way that we've reduced the amount of time that we have with patients, the way that we are seeing the volume of patients that we're seeing. I don't think this is a clinician's problem. I think it's a system problem that we're not being able to sit there and critically think about. This is a thing. Let me explore this further. Let me spend some time away from patients and maybe plan this session and see, she said these problems are here, and then these are the things that I'm working on, but this didn't work. What does it look like to, maybe I need to look at this way. I'm opening up your books all the time, and I'm like, well, what are the symptoms from these things? And because there's complex people. Not all the time are things going to be as clear as we want them to be. I think we're talking in theory here, and it feels good, and you're like, oh, point and release and easy. It can get quite complex. And so I just really appreciate the fact that he's like, I'm going to explore this further. He developed a couple hundred tender points on his own. And then from there, you took that foundation that he laid and expanded it wildly, which actually maybe brings us to our next question. Like, this is probably the number one question I get in my practice for the last 3 years. Brian, how did you figure this out? Obviously, the tender points and touch inhibition, but at some point you related it to a cranial scan. Let's talk about what that cranial scan is and how did that come about? We have the psoas-itis, the L2, flexed L2 with Dr. Jones. There has got to be a story of, this is how I figured out the cranial scan and that this is related to tender points in the body.
So what Dr. Dave there is referring to is that in Jones's day, it was simply a palpatory rapid process of his upwards of 200 tender points. They were tense and tender. You feel them. So we would rapidly go through between each round of releases. Okay, we released that layer. What's next? 200 tender points, and you're doing it bilaterally. That was time consuming. And then you found some cases a whole lot of tender points. So then you're like, which one of these is primary and which ones are secondary? So he would do the worst first. Those were just general rules. And so there was quite a bit of a, shotgun in the dark at times because there wasn't a really nice process to it. And sometimes it was just miraculous, one and done. And other times that point, as we know today, is what we call a secondary hyperalgesia. It was a secondary point and you never did find the primary one. And then you're like, okay, that came back. So I clearly missed it. So I came in probably early 1990s. I was, as you and I were saying, already training and, high velocity and MOBs and Tervel work. And I had a case where I had a clinician fix someone I could not fix using visceral work. It was kidney visceral work, and that person had chronic thoracolumbar, T11, T12 ribs type pain. Then I started studying the viscera. And I realized there was this whole world of deep visceral fascial tightness, none of which matched any of the Jones points that were there. And I taught it, so I knew them all. Then I'm like, wow, there's a whole other fascial system here. At that time, if you train under Barral or some of the French that were teaching that, it was a direct technique. You would go in to a restricted area of the intestine and you would mobilize it, or an in-speared liver and you would torque it into X-spear. I felt the same resistance back in the musculoskeletal days when I was using a direct technique going the wrong direction. Out of frustration with one of these patients, I went in the direction of ease. I counterstrained that organ restriction, and sure enough, felt this softening, this therapeutic pulse as the swelling drains. I'm like, okay, that's good. And it worked. It knocked it out, one and done. That person was like, why didn't you do that before? So I was like, wait a minute, we can use counterstrain on these organs, and started experimenting as Jones did. And every restriction I found, every one I was taught, I started taking it in the direction of ease, correlating it to surface tender points, and ended up mapping out about 60 visceral-based tender points. And that was the first class that I introduced to the group after Jones passed. So now I had 260 tender points to poke. And managed care hit hard at that time. So it got to the point where there was capitation. So, for example, in Maryland, there was a now defunct company called Nile Care. We used to call it Denial Care. And they gave you $5 for the case. And they could come unlimited. So that was a problem, because after about 2 to 3 visits worth of work, it's now free. Your clinic's filling up. And if you did really good work on them, they wanted you to work on other areas, but the insurance company would say, well, we consider that related. People just start saying, we're only doing 15 minutes because we got to get paid for a couple of these per hour. So the owners were knocking it down to quarter-hour patients, 15 minutes. And as a manual therapist, can you imagine doing a subjective and people running late with traffic and trying to do 15-minute patients? So I was almost to the point where I'm like, I can't check 260 tender points and get 3 or 4 rounds of releases done to make a difference in these people. So then I started taking my motion testing skills, and I started saying, well, where are they stuck rapidly? They're stuck in T4-5. And then I would check that most stuck area for tender points. That was a big breakthrough. I started saying, wait a minute, I can use my motion testing skills to find the area of greatest restriction, then do the Jones to see what the source was, treat it.
So let's stop you right there. What made you decide to use your motion? What was the link between, if I motion test the spine, that's the segment I want to treat first?
Yeah, so I knew that these tender points per Jones and per the knowledge that we did have of the day were definitely presenting into the spinal cord, as we discussed. So I was like, can I take the 2 different philosophies, take the joint stuff, where are you most stuck, which I was taught by these guys, and then take the Jones stuff, which really showed me the source that I could drain with the indirect, and put those 2 together. So that was just an early me taking other parts of manual therapy and combining it with the Jones concept. Okay.
So then you got your motion testing, which narrowed it down a little bit.
Yes.
All right.
So I didn't check 200 anymore. I might be checking 30.
Yeah. So then you're in the segment, you're in the area, you're working that, and you might do that a few times.
Yep.
How did you get from the spine to the head?
I realized that a lot of these really involve visceral people because of the pleura, how big it is, because of the mesentery, how long, they were just stuck everywhere. And I realized those are the visceral people. And, you know, they're the ones that are bogging me down because they weren't just a L5 problem that I could release with counterstrain. So then I was like, there's got to be a way where I can knock out a lot of this visceral inflammation. And I knew enough from doing cranial work at Michigan State, jugular foramen, vagus nerve. I'm like, I wonder if I can go up and do some of my cranial work and unlock the jugular foramen. And will that, through vagus sensory impact, lessen the amount of visceral points I would do in those full body thorax visceral people that I knew had a lot of visceral points. So I started saying, all right, let me try working in that area of the cranium and brainstem where the autonomic nervous system starts in those patients. And wonderful theory didn't work. Okay, it worked. But what happened was I did realize I couldn't decompress it and make all those points go away. And a lot of that has to do with the fact of the enteric nervous system, because gut talks to gut. a lot. It's not all coming from there. Okay. It reports through that nerve. It's not driven by that inflammation or nerve. But here was the breakthrough. I realized that every single person with a lot of visceral stuff, their mastoid process, right near that jugular foramen, was very rigid and sensitive. And as I treated the viscera, it would become less. And if they didn't have any tightness and rigidity there, I tended to not find any visceral points. So it became my quick motion test was the mastoid. Do I need to check my new visceral points? Yes or no? And it did work for that.
So what I'm hearing is that you essentially had a theory that was wrong, but
Yes.
it kind of led you to realize that there was a lot of rigidity. And by the way, everyone, the mastoid process is the bone behind your ear. It kind of sticks out like a knob.
Yep.
It's kind of shaped like an egg. And that bone was rigid. And you're like, well, how is the bone rigid? That is a whole other conversation. And so essentially you found that it was rigid and sensitive, and it correlated to the visceral dysfunction.
Yes.
And it's all based through the way that the nervous system communicates with one another. Is that correct?
Yeah. So the viscera is reporting up through the vagus nerve into that area. There's all nerves connect into the epineurium and the dura, which goes into the cranium in the anatomy world. So it is a, let's call it epineural, dural sensory manifestation in the dura, which you feel all the way into the bone. So that was the first thing that sped me up. Then I noticed that it was more specific than that. The people with the front visceral tender points, the mastoid was more stuck on the front, more tender and tight. And the people with the posterior pleura, retroperitoneal organ points, they were on the back. Then I realized the ones that were the lower organs like bladder were stuck on the bottom. Top organs like the upper pleural dome were stuck on the top. So it became a little mini homunculus of, I know not only that that's a visceral person, but I can predict where the visceral point is through the cranium. So that was the start of the cranial scan.
And Brian, the same curiosity that Dr. Jones originally had in 1955 is the same curiosity that you used to take this body of work to the next level. It's humbling to hear you go through this process, because there's probably a lot of clinicians out there that are like, I'm trying to problem solve and I don't know if I have the time. This is what the practice of medicine, of physical therapy or chiropractic is. Clinicians taking the body of work that we've learned and apply it in a masterful way, saying, look, I'm not happy with what I'm doing. Let me see and theorize. You're a great example. You had a wrong theory that led to a breakthrough. You must have been excited every time it worked.
Yeah, it's always a bunch of mini discoveries that you're not sure it's right at first.
Yeah.
And then the next day you're like, dang, I think that's right. And then pretty soon it's right. So it's not quite a, woo, it's not like hitting a home run or anything. But like, I think I'm onto something. I think that worked, and that's where it always starts.
As a new grad PT or a young clinician, there are two things you need: mentorship and money. We will pay you a full salary to be mentored in our customized residency program right here, and it will actually help you fix those patients you could have helped more and prepare you to launch your own business one day if that's something you want. Apply at our website and click Join Our Team at www.renewintegrativept.com, and we look forward to hearing from you then.
If I look back at Jones, there was a sense of he was a very good observer.
Yes.
And pattern recognition. I think those are two things he and I have in common. And then a desire or a bit of being a perfectionist, like wanting to help fix everybody. Yeah. That can drive you. It's a fault being a perfectionist, but I've said this to foundations classes and people say, how do I know I'm one of you guys? You have to learn all the anatomy in the entire body and all the science. But the way you know is that if you go home at the end of the day and you helped one person and you're bragging to your spouse about that one person you helped, you're not one of us. Okay. But if you go home and you're like, I got this one patient I can't figure out and it's driving me crazy, you're one of us. So it's your personality type. So I think a bit of desperation trying to help people. In my case, it was like, I want to help these people. I also don't want to quit doing counterstrain. I'm finding most rewarding in the world, this new technique, and managed care is trying to take it away from me. I got to find a way to do this.
Yeah. I always joke, I'm like, with my patients, I'm like, fortunately for you, I'm a perfectionist, because they're like, well, it feels pretty good. Thank you so much, Dr. Dave. And I'm like, I'm not good with that. It's not, I'm glad it's 80% better, but I'm not happy with that. And I always joke with them. I say, for you, I'm a perfectionist. Unfortunate for my wife. She deals with me. I'm constantly focused on these things. God bless the women behind us because they deal with us in gracious ways too. But that's sometimes what's necessary to take things forward. So let's take it back. So you went through the mastoid process. Then you started to find more patterns in the head.
So then that led me to the science of fascia. Since I'm treating what I now know were visceral ligaments, I called Jay Shah at NIH. He's on the stasis paper. He's one of the most famous fascial scientists in the world right now. I met Jay because he was a patient of mine. And Jay did the original sampling studies that were done with a microdialysis needle that show that this trapped inflammation is present. It's been proven via interstitial sampling around active trigger points. That study made Jay keynote speaker at fascia congresses, and he's all over the world. The inspiration for him to do that study was me telling him that's what I think I'm doing, because he asked me, what the hell are you doing? I said, from what we can tell, we're draining trapped inflammation. And he's like, no one's ever shown that. And I'm like, no one's ever tried. So Jay was very in tune with the research at National Institute of Health and around the world. And I just repeatedly released these visceral ligaments. So I emailed Jay and I said, Jay, is fascia contractile? And he's like, not that I know of. Why? I'm like, because it is. And he's like, really? I said, yes, I'm treating visceral ligaments very consistently and it's not skeletal muscle. So long story short, he got back to me after the 1999 Fascia Congress. The ligament contraction study by Yahya was out, that they actually showed there were myofibroblasts and they contracted. So he shot me back. He's like, well, yeah, they just proved that connective tissue is contractile. So that was then my pattern recognition to, well, heck, if I can treat this fascia, we're already treating myofascia. What stops me from treating all fascia? So I started looking into the science of fascia that was there at the time. I'm like, wow, this stuff is histologically the same. It's got pain receptors in it, right? It's got a blood supply. It's got neurology. The tunica adventitia of the vessels is fascia. The epineurium of the nerve is fascia. The dura is fascia, ligaments, tendons. I started experimenting along the neurovascular bundle on people with tingling and weird things, and I felt these restrictions. And the second thing I mapped out was the venous and lymphatic system. If there's a cranial scan for the viscera in the mastoid, is there anything that changes in the cranium when I fix that system? What I saw was that the parietal bones freed. So I would go up and check the parietal bones, any lymphatic stuff going on. And then I could check the mastoid. Was there any visceral stuff going on? And at all those points, I knew to check them or not. So that's how it started.
So you leapt from the mastoid, which is the visceral system, and said, well, if it's true for the visceral system, maybe it's true for the lymphatic system, the venous lymphatic system. And that's what brought you to the parietal bones.
Again, I was cranial trained at Michigan State Osteopathic. Yep. So I already knew how to do quadrant testing of the cranium. There was some coincidental or God-inspired things that had occurred in my life that put some skills and some experiences in my toolbox that allowed me to recognize these patterns.
And so from there, system after system, it built with that same pattern recognition model throughout the whole thing. And obviously it's still expanding today. It seems like every time we retake a class, it's like, by the way, I found more things.
Now we're talking 2022, 2023, some of the science related to the neurology of the body and how it impacts the dura. So the cranial scan, I always say in the foundations of Fascial Counterstrain first class, it is the part that has the least science known to it at this point. It's very empirically derived. But I can give you what is very likely happening based on the latest science. As a practitioner, many osteopaths have said this to me as well. Without this assessment tool, this proprietary cranial scan that can be done in 30, 40 seconds, where you can tell every single system and subsystem what is that next worst layer of fascial dysfunction, or where is the greatest restriction / greatest inflammation area of trapped inflammation, all through the cranial scan. And you can do it under 30 seconds. And we're not just talking lymphatic system.
Yeah.
Dave can tell you, we can tell you it's the lymphatics in your right ankle.
Yeah.
It is the lymphatics of your viscera. It is the lymphatics of the head or veins. It's very specific. So you only have to check a very small number of tender points. This very large body of 1,000 potential tender points narrows instantly by using the cranial scan.
A lot of patients are like, well, what does my head have to do with my ankle? My simplistic explanation is that they're connected through the nervous system and they communicate with one another. People understand the mechanical model, but when I say the nervous system communicates with itself, they're like, oh yeah, that makes more sense to me. I keep it very simple and say that what's interesting is I can feel that. And what really blows their mind is that you alluded to it earlier, the touch inhibition. We can turn these points off by some light touch on the different points and the different cranial scans in the head to confirm that what we feel is real and true, because there's some ways that we can get confused. By confirming that that tender point and that part of the head correlate together with tissue's rigidity and softness, we can actually confirm that what I'm about to do is actually going to help you. I think that was another mind-blowing thing for me, is that my evaluation process was a series of test-retest model. Okay, you have shoulder pain. Let's see if you got some hypomobility in your shoulder, you got some muscle trigger points. Let's see which one's more important. I'll take 10, 15 minutes, mobilize or do some soft tissue work, and then see if it's going to help them or not. And it's a good model. It's helpful. It does serve people well. But now at this point with Counterstrain, I can turn a point off and then see right away if it actually is going to help them before I spend the time treating, which I think is just a novel concept for most clinicians, is to predict when we're going to help them with certain techniques.
Yes, another way I like to say this is that there's been hundreds of talented osteopaths, hands-on clinicians over time that used intuition, wonderful hands, good knowledge of 3D anatomy, but were unable to develop a process that would allow less experienced people to get the same results. So I've always done two things. Take this technique that, in my humble opinion, is the way, and say, can we turn this into a process? Can we expand it to all tissues, all systems? Can we understand the physiology behind tender point formation and muscle guarding reflexes and dysautonomia? Understand the embryology of how it's all connected, put the science behind it. And then can we come up with a practical group of quick tests that sorts through all of these primary and secondary tender points and says, that's the next guy, treat it right now. So you can use this massive amount of work in the real-time clinical setting. So it's process, right? So I literally have said, I don't want to be the next person that was doing stuff and died with it. Be like, well, AT Still, he was doing all this stuff back in the day, but nobody's doing it today anymore because he died with it. And, not bashing, I'm saying you have to come up, support it with the science so you don't head off in the wrong direction, and you can mainstream it. Come up with a process that allows a person who just goes through your curriculum to get the same results you do. You don't have to have 35 years and 70, 80,000 hours of study to get the results. There are people in my clinic, like one of my guys that's just starting with me now, he's been counseling for 3 years. He's already working on the brain because he just learned the process. And his results are 85, 90% of mine in 3 years. That's the goal.
And I think you're already starting to define what a good outcome is for your clinical practice, for your lifetime in the professional world. You don't want to die with this. You want to raise up the next generation of clinicians. You want to systemize this in a way that maybe in the future is built upon. And it's funny, you mentioned some of the research hasn't quite caught up to some of the theories that you're using.
Or even the human hand.
That is true. The reality is some of the greatest things in medical advancement started off not in the literature, not supported by science, but had a theory that then needed to be tested. But you can't just test everything. There's going to be certain practices, and Counterstrain does not fall into this any longer, but it did 20 years ago, where it had to be explored anecdotally to think, is this worth exploring in the research? Otherwise, it would just be every wild, wild west with everyone trying to find stuff out. What you did was you anecdotally built upon precept, first the visceral system, then the venous and arterial system, and then you started seeing more and more patterns to the point where there's really something going on here.
One of my research friends works for DOD, published 76 times. She said to me one time, she said, don't let anyone ever tell you you didn't develop this with research. She said, repeated observation with repeated outcomes is research. She said, you're doing clinical research. You go bedside to bench, meaning it works. Now let me try and figure out what it is, versus like microscope to bedside, like repeated outcomes and observations done over and over and over again is research.
100%.
But I'm trying to put the two together and say, okay, let's be able to, anyone who says, wait a minute, you got to be able to explain at least how that's theoretically possible. Get there. We've got it in a process that we can reproduce. And now we can say, here's the problem, here's the method, and we'll start to produce outcomes and measure this. So the next stage where I'm headed is finish out the development of the central nervous system, 3 or 4 classes. And then let's start, because we've got the 2 citations we need. This is the problem, trapped inflammation. This is the method. This is how we find it. This is how we get rid of it. Now let's measure the outcome. That's stage 3. Okay.
And I'll tell you empirically, my outcomes have never been better. They are faster, more complete, more thorough, more widespread than they've ever been with this technique. And I think a lot of people ask, like, well, how did you come up with this? It sounds like there's a couple theories that kind of helped you along the way. I know this because we've had these conversations, hours upon hours of study of the anatomy, the research.
Yeah, I estimated between practicing, teaching, studying to teach, and doing research, about 80,000 hours. And that was years ago. So you're supposed to be an expert at 10,000 hours. So I'm like, I should be pretty good at this, or I found the wrong profession after 80,000. But the nice thing is, in a limited curriculum, that knowledge can be given, right? It can be imparted because there is a process.
So you're talking about the science aspect of this, and I think we've established that. But I want to go back to your own bio, something that you've repeatedly mentioned in your own research that is published. You have consistently given God acknowledgement and recognizing that some of the divine insight has made this work possible. Can you expound on what that means?
Yeah, I mean, I've always been a person of faith. I was brought up with it. There wasn't one particular time in my life where I found God. I just was brought up. And so then there's so much you could call serendipity in my life. And looking back, all these pieces just lined up. Jones. I was a 23-year-old in one of his classes, asked him a couple tough questions, and he's suddenly like, how do you know that? Next thing, he's inviting me to teach, to be a volunteer. Out of all his students, things happen that way. But I always say that this work, all that is good comes from God. Evil is not God. So in this work, it's nothing but a blessing to those who receive it. And it comes so easily to me, even though I talk about 80,000 hours, all the studying I do. But I just know when it's right. And I can't explain it. People say, well, how did you know to go this way than that way? And as a fellow Christian, I feel it in my spirit. I feel it when it's wrong. And I know when it's right. And I'm like, it's not ready yet. They're like, well, what do you mean it's not ready? It's just not ready yet because I just know it. I can't explain that part. And there have been points where I've been stuck. I just reached a plateau. And I ask, I'll pray, God, I need some insight. I'm stuck. And it has popped in my brain at one night. The answer just popped in my brain. Every other time, within a day or two, I have this clinical epiphany on a case and it hits me. And so you don't have to be a Christian to use it, learn it, receive it. But this stuff is smarter than me. The process is beyond me. I just see myself as the messenger.
I love how you put it. You said like there's serendipity. I would call that divine appointments. It's God putting people in your path for a purpose, right? And I've felt that in my own life where God's like, you're going to meet this person and you're going to do this. And every step of the way, you're like, I don't believe in luck. I really believe that there's blessing and there's curse. There's good and there's evil. I'm very much more black and white personally. And so that being said, when you're talking about these times where you're like, yeah, it was God, I resonate with that. And I think a lot of my viewers will too. Another thing that you mentioned I really appreciate is the fact that you're like a word of knowledge where God can speak to our spirit and saying, look, in our Christian world and our faith, the way it works is that God is not silent and that he does speak to his people. No good father does not speak to his son.
Right.
And you're an example of that where you're willing to listen. Sometimes we get into the hustle and bustle of life. We're busy people and we don't take a moment to listen. And how do you expect to get an answer if you're not listening? And you've done that in your life, which is a great testimony to especially young believers that are maybe discovering Counterstrain for the first time. You're like, well, how do I reconcile this with my faith? My wife, actually, who has been treated by you and has gained so much benefit from it, was very profound. She goes, Dave, in the past, no pain, no gain is true and helpful to an extent. But what was really interesting is it's almost like a spiritual experience getting counterstrained. And I'm like, what do you mean? She goes, well, it's how the Father deals with us. It's not painful. It's gentle. and in the past it's been a little bit rough and direct, but the reality is that counterstrain is exactly how God deals with our hearts in a spiritual sense. And it's just a physical manifestation of that. It's an analogy, it's a parallel. In the physical, we can actually drain out the bad through a gentle technique that turns off bad things. And in the same way, God can do something with us spiritually, turn off bad things, turn off those bad desires, or improve the way that you're able to externally produce the fruit of His Spirit in not only your own life, but others' lives. And the last thing I'll say, that, and I'm passionate about this, we will know good and evil by its fruit. And I think that goes back, like I can go all the way back to my first class in Counterstrain. I saw the fruit. I can be a very ornery person and a very skeptical person. I think I may have annoyed you a few classes, how often I was coming to you with questions, but it was never in a sense of...
No, it was respectful.
I never wanted to, not to disrespect you, but once I had come to terms with things, I was like, I'm in. And the reason why is because I was able to see the outcomes of it. I took my second course, which was one of the nerve courses. I don't recommend that. That was hard.
Tough for a second class.
I got some of the trigeminal nerve treatments in that class, and I went home and I had a patient that I've been treating for a long time on a regular basis, and I treated out her trigeminal nerve, and all of her trigeminal neuralgia went away. I was brought to tears about that.
That's the suicide nerve, right?
Yes. People kill themselves over this. I brought her relief, and it's not come back. I'm blown away by those kinds of outcomes. And those experiences, I'm like, I know it by its fruit. You've been through it longer than I have. You've been around the block and had more training before my Counterstrain years than I had. And I do not see any hands-on technique that comes close to how powerful and broad Counterstrain is for people. I'm an apologist for it. There's multiple clinicians here in Pensacola now that are going to your classes because I'm like, you need to learn about this. You're my competitor, but I don't care because of how beneficial it is.
I teach them right in my clinic, you know that. And when you're looking at all systems, including the central nervous system, post-concussion syndrome, loss of executive function, photophobia, chronic headaches, migraines, things like ringing in the ears, tinnitus, trigeminal neuralgia. When you get into the brainstem, you're affecting the medulla. You're talking digestion, heart rate, blood pressure, chronic pain, so many things that are swelling in this area. The hand, feeling the tender points and the rigidity, is picking up dysfunction in the microvascular system and picking up small elevation and intracranial pressure, which medicine cannot image right now. It cannot image it. And through this paradigm, we can diagnose it and we can remove it. And it's basically undiagnosable. They just call them syndromes. So back to the divine nature of God's body, there's a diagnostic tender point on the surface and this motion test of the cranium that tells us the function of every single thing inside the body. Tell me how that just evolved, right? It's like, why are they there? Because we're supposed to find them. We're supposed to use them. And I don't want to say this. I want to say this with the most humility because I treat a very tough caseload. People fly in from out of the country and out of the state. I often don't see a person from Maryland all day long. These people commonly in 3 days, they're 70, 80% fine. And they've seen 40, 50 practitioners and had every test. And within a few minutes, I'm like, I feel it. I see it. I see what it is. And many of them start crying exactly where that point is. And no one's ever explained that. I'm validated. How come no one could find this? Because the human hand through this process is ahead of the imaging. Like CTE, chronic traumatic encephalopathy, the football thing. It's basically diagnosed post-mortem. Here are these people, they have all these neural tangles and tau proteins and edema, and they have to die and dissect their brain. But you and I can put our hands on their head and say, you have a pressurized cranium. Okay? They just, in the last 2 years, started, so intracranial pressure, when it gets to a certain point, they have to put a shunt in, or you'll die, okay? Or you'll have severe neurological problems. But a few millimeters less than that, they were saying, you're fine. It's benign. Okay. And there's ventriculomegaly. The ventricles are expanded. They're full of extra fluid, big cavities. Don't worry about it. Now they followed those people all the way up to the nursing home, and they have cerebellar ataxia, chronic bladder problems, vascular dementia. They're not all right. Our human hand, we can pick up where that head's pressurized and feel it and treat it. There's no imaging that can do that right now. They're following these people and saying, until it blows up those ventricles or they measure it at that really high level, don't worry about it. And the last thing I want to say too is the human body does not function in a compartmentalized sense. An ankle doesn't function without the foot. An ankle doesn't function without the knee. An ankle doesn't function without its neurology and vascularity that comes from the heart, comes from the spinal cord, and eventually coming from the brainstem. So in medicine, we tend to be, I'm a foot guy. Well, you can't be a foot guy and not be a kinetic chain back guy and all the way up guy. So you do need to learn the whole body, and you do need to look at a multi-system paradigm, peripheral and central nervous system, if you want to take these cases that did not respond to that local treatment. So the idea that we've just taken the body and said, just treat the shoulder. How do you treat a shoulder and not treat the clavicle and the ribs and the spinal cord? I mean, it's complex, right? That's what we've built here is let's look at the whole system from the central out, and let's have a process that says of all these tight areas, which one's dominant, who's the driver, right? What's the source? Then a very elegant, painless technique to drain, reassess. So the process walks you right through it. And every day you're like, whoa, I wouldn't have started there on that pain complaint, but the process took you there.
The first thing I want to bring up is the fact that you essentially are talking about the way that the medical system has broken up into segment and how specialization has been a disservice to people. Like, what do you suggest we do? So that you're identifying what you'd consider a problem. Like, it's not helpful that you're a foot guy, but you don't understand the brain. And again, not a clinician's fault. It's just kind of how we've done it. What do we do about that?
I think specialization probably started in surgeries where it is necessary. And then they were like, and then they said they took it past surgery to be like, I'm just going to look at the heart. Like, the brain doesn't communicate with the heart and the spinal cord. It's like, let's pretend it's just the heart, And so what do we do with these non-life-threatening things? Symptom controlling medications, typically, right? So they're just throwing medications at symptoms because the source is not sought. So I really would say, this is kind of a new medical model where we are not a specialist in anything. We understand the entire body and its reflexive interrelationships. In a weird way, the whole body is run by reflexes, changes and compensations. And you have to understand all that, not just a mechanical level, because mechanics matter, right? But at a neurophysiological vascular level, and understanding how that input comes and goes from the brain as well. I'll give you a real quick example. The doctor, she was a PTSD doctor, was on one of my research papers. At one point, one of her sons had a lot of tics, and they didn't know what to do about it. And the father had counted almost 400 in a 5-minute span of neck tics. So I had treated her quite a bit, and she was like, have you ever had a positive response to this? I'm like, I have. I'd say I've definitely seen it go away. It was years ago. I didn't know the brain like I do today, but I'm like, I'm more than willing to take a look at it. So anyway, turns out that the father is a brain scientist. And he said to this doctor, associate of mine, there's no way you can fix that because it comes from the brain. And so anyway, he shows up with the son. And when I'm assessing him, his upper thoracic spine, upper cervical spine, a mess. Sympathetic drive is going crazy. For laypersons, the blood supply to the brain comes from the heart up. And the neurology that controls the tone of the vessels is also coming from the neck up. When you change that flow in and out of the brain, you change inflammation in the brain. You change how neurons fire. You change the health. And so I did one session of neck work. He was mainly a neck, and it dropped 50%. And he said to me, down 50%. And as a researcher, he goes, it's a clear reduction, but I can't say it's causation. That's what he says to me. So I was like, well, what do I got to do for causation? He goes, you knock it the rest of the way, I'll give you causation. Second session, it was gone. The reason I made that was his paradigm was nothing affects the brain but the brain. I'm like, of course the blood flow into the brain affects the brain. You would think it was kind of intuitive that let's look a little below the brain because it kind of matters what comes into the brain, but it's just training, right? So I want to go back to the word process because this is so complex of the amount of things that go wrong, that the process, the tests, the motion, the scans have to lead you to it.
Yeah.
And when you go through the process all day long, happens to me as well, I'm like, I hear that symptom, I've got some theories, but until I do these tests, I really have no idea.
Mm-hmm.
And many times my hypothesis was, nope, that's wrong. And they're like, okay, wouldn't have gone there first.
So then tell me, what is one of the testimonies, like again, I gave that testimony of the trigeminal neuralgia. What is one of the ones that touch your heart that you were like, man, God just showed me, they gave me this testimony. This is something that you hold that you're like, this was a thing, or man, whether it was the timing of it or maybe it was the person, like, is there a testimony that is close to your heart that you're like, man, I'm really thankful that God aligned this to occur?
Yeah, I would say a lot of that happens in some of the psychiatric world where people come in with severe depression, anxiety, and a lot of them feel like, they're crazy. And we just published a study on rapid reduction of PTSD with, post-traumatic stress disorder using fascial counterstrain. It was published in Military Medicine. We took 12 or 13 first responders, did 3 hours of counterstrain, targeted to the nervous system, the fight or flight system, drained the inflammation out of it, and 12 out of 13 tested below the threshold for PTSD all the way through 6 months. 3 hours of hands-on treatment, no drugs. And these are people that had already been through things and still had PTSD, psychiatrics, medications. Some of these people have taken themselves out of society because they don't trust. They're going to have a panic attack. They're going to overreact. They're going to hurt someone. A lot of these people have served our country in the military, and you can so consistently change those people. And they come back, and it's like literally a day later, they're like, my life's back. I know I'm not crazy. So I really enjoy that. Pain is pain. We help pain, digestion. People walk who weren't walking well before. But when you can change through manipulation someone's entire personality, get them sleeping again, get them being able to relate to their kids, get in their life, say, I can talk to him again, get him to, who doesn't want to hide anymore, wants to go back into the world, doesn't commit suicide, like 14, 15% of them do. Those are the ones that I think that part's very, very exciting.
So you're even just alluding to, and again, we don't go around saying we treat PTSD at this point, right?
But it's a pilot study, and we're looking for more funding. Okay, so we're not going to say we've proven it, but I did put in that article. So looking at the philosophy, the key thing you have to understand is that when you get inflammation on a nerve, the nerve becomes sensitized. And the stimulus necessary to make that nerve fire goes down.
It'll fire more easily.
So we call it threshold of activation lowers. So like on a pain nerve, if you inflame my pain nerve, you can just touch me and I'll be, oh, that hurt. It's called allodynia. That's an inflamed pain pathway, right? Well, the same thing happens on the sympathetic fight or flight nerves. They get inflamed. So then it takes a very small stimulus. Somebody cuts you off in traffic and boom, you blow up. Wait a minute, how does stress, if they don't have a head injury, it turns out that the fight or flight circuit in the brain stimulates the immune cells of the brain. They dump inflammation. Chronic severe stress causes an inflammatory pathway on those neurons, which then makes us way more hypervigilant, which can be protective. If I'm being abused or I'm in the theater of war and I'm constantly stressed, the body through that inflammation creates an inflamed brain, it lowers your activation. We can go in and physically drain it back out. And it is not something that the body self-absorbs. It lowers your whole, it's called allostasis. You had homeostasis here, now it's too low. Your new set point's way down here. And it's physical. You can't talk these people out of this. So this is a physical inflammation treatment of that fight or flight pathway. And I'm not saying people don't go through psychiatry. They don't need medication if they're suicidal. But we can get to that and drain it and ramp them back up to the raw baseline. Life-changing stuff, 3 hours of work.
That's amazing.
But again, all we have is a pilot study at this point. But why we did it was because all those first responders, they put up the money. These were people who were vets who were like, I want this out now. And they're like, they started donating us money. That's why we even did that study. So it is a little, cart ahead of the horse there because I need these other studies out. But they're like, this has got to get out there. Yeah.
That's really cool. So you got the patients funding it, which is just
the patients,
mind-boggling. I don't think we've ever had that before. We need to recognize, again, the testimonies for this treatment modality is obviously just outstanding. You brought up the fight or flight system, some trauma, what that can cause.
The body holds the score. There's
I
books
was going
been
to ask
on
you
these.
how that
They're
can be.
observing a significantly increased musculoskeletal injuries of people with PTSD. So we know this physiology has changed. And I'm saying it hooks really nicely into this trapped inflammation pathway and all the way into the psychological
Yes.
fight or flight system, making those glial cells produce inflammation. I believe is the body's way of making us hypersensitive to threat. Problem is, doesn't come with an egg timer and doesn't go ding, you're out of war. You're now there.
Yeah.
We can go back in, and when we start to hit these locations related to that fight or flight system, people are like, that's my spot. I know that spot.
Yeah.
Let's say there's an indication that we should study more. Let's put it this way.
Then let me ask a more clear question. What do you think about the work of the body keeping the score? And then how does that directly relate to the counterstrain work?
Well, I mean, when you impact the fight or flight nerves, that goes right in to what I talked about before, that autonomic part of the cord. Those nerves go to organs and vessels. So now you can start to have your hypothalamus, pituitary, adrenal axis can be up, throws off your norepinephrine and cortisol levels, overworks your heart, you get tachycardia, you can get kidney disease. These are all associated with elevated sympathetic drive. The vasoconstriction caused by those nerves starts to cause organ problems. So you start to become damaged from that stress event if it's ongoing. Okay. Mm-hmm. Chronic elevated sympathetic drive creates a reduction of blood flow to everything but the heart, which it overworks, and create cardiomegaly, can damage your heart. So it's basically take all the blood from here, make the heart race like crazy, and neither one of them wants that. They all want their normal blood flow.
So what I'm hearing from you, that essentially we can have an initial trauma response that creates inflammation in our sympathetic nervous system.
Because the sympathetic nervous system drives the immune system, creates inflammation.
And then creates a loop of more.
In that lymphatic system, it gets trapped. Yeah.
And then it has all the systemic problems. And so people go around saying, yeah, the body keeps the score. Well, really what's going on is it traps the score maybe.
So one of the ways those cytokines, this trapped inflammation, I call it interstitial inflammatory stasis. Okay, mm-hmm. But that it can be the interstitial fluid of the brain as well, and lymphatic mm-hmm. system of the brain, is those cytokines are produced by immune responses. And one way you can crank up the immune system besides viruses and infections, which by the way, long COVID, what is that? It's an immune response, right? And did people have vaccine reactions? Yes, they did, because it cranks up your immune response, particularly if you're carrying a lot of stuff on when you go get that shot. So, immune responses do it, viruses, infections, traumas, but also cranking up the sympathetic nervous system with thought. So we all know you're probably just stressed. That's why all these things are happening to you. Stress does physiological stuff. It's not a phantom psychological entity. It has a physiological effect on the body. And if it's ongoing, because of this cytokine loop, now it becomes truly damaging to your body.
And then because of the cytokines lowering the threshold of these nerves, you're like, oh, my stress is causing the problems. Well, chicken or the egg, who knows? There could be one or the other, trauma, therefore stress, or maybe the stress ongoing is causing it to start. But what we're saying here is that people who are stressed might have all these symptoms more often because the threshold to cause this dysfunction is much lower.
Yes.
Right? And so people go, yeah, I'm just stressed out. It's why I'm having this problem. And I just need to have less stress. I'm like, we can actually treat the reason why your stress affects you so much.
Yeah, or you went through that event, you had a death of a loved one, tough childhood, child, spouse, whatever issues. And if that's ongoing, the sympathetic system should fire and come back down.
Yes.
If it's repeatedly cranked up, it does sensitize itself. And then it does not automatically go back down. Yeah. Right? So again, we're not saying this is a proven theory, but it is one of these many pathways we treat. Clinically, there's very encouraging results, needs more study. Yeah. But I find that whole thing fascinating, that we can use a physical modality and people are suddenly sleeping better, their personality changes. And these PTSD people, they don't come in optimistic because nothing has worked. Yeah. Okay? I've had 2 people last month, back to back, showed me I was the 48th and 49th practitioner they had seen. So they're not coming in thinking, yeah, it's going to work. I mean, they've had 49 people they've seen and no one was able to help them. So like, people say, oh, it's just a placebo effect. I'm like, well, they had it for 20 years, saw 40 people, right? And, we see changes in blood work. I've got blood work changes and, just all types of things. We're starting to see that. We're going to start to research this and show the physiological changes. My dad, off his, CPAP, no longer needs it, and his pulmonary hypertension also went away. Yeah. And I treated him 2 times. One was a Christmas Eve when he was visiting. CPAP numbers say he doesn't have it. And then the doc said, I don't want you going off of that because you have pulmonary hypertension. He's like, well, look at my numbers. She said, well, okay, but you got to see your pulmonologist. She came out and said, I don't know where your pulmonary hypertension went, but it's gone. So these are organ changes from dysfunction, not disease, right? And so we've got to make that distinction. Is this a cure-all? No, you can have structural damage, genetic things. We're not going to fix those things. But so many cases, it's tissue that is malfunctioning, like your nervous system's malfunctioning, or you've got chronic pain. They're like, I don't see any more arthritis here than I see in everybody. I don't know where it's there. That's where this paradigm comes in.
You mentioned like people are not coming in expecting results. I literally had an evaluation last week that she said, I'm here because my best friend forced me. I don't want to. She literally said this to me. She's like, I'm here because I need to prove my friend wrong. And she showed me her x-rays and her knee had all the bad things. It didn't look great. I'm like, okay, game on. Let's see what I can do. And then to see the change of working on her back and making her knee feel better with the diagnostic process that we use. Yeah. I'm like, and then she's walking around, she goes, and she looks at me. She's like, I'm going to have to tell her it worked. And it's
darn it.
And it's those that I love those testimonies, and it feeds my soul. It's not a brag. We can sit here and talk all day about all the cool things we do, but it's those things that feed our souls. Yeah. It's like it makes me go home and say, okay, I can do this again tomorrow. I've had plenty of clinicians call, text me and say, hey, I want to come take the class. I'm only 3 years into the journey. I went through it quickly though. I have a lot of people reach out to me and say, hey, Dave, can you tell me things? I tell them that this is hard work. This is not an easy process. You have made it almost foolproof if you just spend time studying and learning because of the process that you've developed. But when you get down to it, this is probably the hardest thing I've ever done. I don't know anything that it's been. I think that's one of the reasons why there's not as many counterstrainers in the world yet.
Right.
Not everyone's a counterstrainer because of the personality that you alluded to earlier. Even if you find those people, you have to have the mental toughness and truly the drive, perseverance to go through this process to learn.
And treat those difficult cases all day long, because we have gotten the reputation of, if everything else failed, go get some counterstrain. Okay, that's the group we get, because the orthos have their own exercise therapists, the teams have their own trainers. So we get the people, like the lady you said, they've done everything, and that's the world. It's the world I developed this in. The group I now treat intentionally have gone through everything and then seen a high-level counterstrainer and still have a problem. So I want you guys peeling off everything that is known and then send them so I can work on the unknown. And I just fill my day with those people. Like I said, I can only do 4 days of it because these people are just laying out. Their lady was crying to me today, telling about how much she can't take care of her husband who's got a bone disease and she's got so much vertigo and she's just crying about her life. I can only do so many days of that, but I bet you tomorrow looks like things went well, that she'll come in with a smile. Okay. If your health is not there, your life is on hold. Nothing else matters. And these people fly in for 2 or 3 days, or they're coming to you and you're like, you're my last hope. I had 2 ladies 1 year in 1 week said to me, you're the last thing I'm trying, and then I'm committing suicide. 2 in 1 week. No pressure.
Yeah, the pressure, your stakes are higher. I mean, I've not had anyone say that.
Yeah, 2 in 1 week.
So
they're both alive today, by the way.
The pressure that we put on ourselves is pretty high. It's not like I want to perform so I look good either. It's because we know we're changing lives, and the pressure is higher on you. At least I know I can send people to you and some of the other high-level counterstrainers that I've referred to. Wonderful practitioners around the country that I've learned so much from and still gain in information. I still have an outlet. You don't have an outlet. How do you deal with that mentally? How do you deal with the fact that people are saying, I'm going to commit suicide if you don't fix me right now?
Yeah, well, that's where my faith comes in again. So I just often say a prayer, send me somebody I can help, or somebody at very least I can empathize with and learn something from. And pretty much that's what happens every time. A little bit of both. Because taking the lady I was telling you about, she had this massive disequilibrium, cerebellar ataxia. And at the end of today, our first session, she was able to walk around. She didn't feel it, which is very unusual for her, but she still had some convergence. So she also has a convergence disorder, and they're actually separate in the brain. And so she said, wow, I feel very different. I feel very good, but I can still see I have convergence. But her convergence was often this way. Her axis of vision was rotated vertically and cross-eyed. And she wore prism glasses, which didn't quick fix all that. She goes, it's level. I'm a little cross-eyed distant, but she goes, but all the weird feeling is so much better. And then so I said, convergence, there are a few difficult cases I have not been able to help. I said, but tomorrow we'll dig in on that, and I want to see what I see in you, so I can figure this out if my standard stuff doesn't work. If I can wear my prism glasses, take care of the rest, I can take care of my husband, my life is so much better. I said, but we'll spend all day tomorrow trying to figure that out for you. That's a typical case. I'm able to help some things, hopefully change their life, but did I cure every single thing they came in with? Those type of people have a laundry list, and that's not the goal.
So we're kind of winding down here, and there's a couple of things I want to get to. And one of the more important things, there's two main questions I want to get to with Counterstrain in your view. I want to speak directly to the counterstrainers out there already. I want you to tell us what separates a good counterstrainer or an excellent top-line counterstrainer from even a good one. What does it look like on our end, looking to you as our guide in this, because you even alluded to it earlier, you're gifted. This is not natural. You have been gifted in this, and this is something that God intended for you to do in your life. God has equipped you for that calling. So now you are kind of the head of the spear of what I see coming as this massive movement. And because of the profound outcomes that it gets, what does it look like for a good counterstrainer that's taken most of the classes, if not all of them, to truly become great in their career in the fascial counterstrain world?
I think you first have to realize, particularly at this day and age, it is in a continually evolving paradigm. So, again, talking to counterstrainers, so like the concept of tethering, endural tethering. So that I saw a group of patients with head injuries, TBI, concussion, that per the process, I had fixed all the vein drainage, all the lymphatic drainage, all the sympathetic drive, artery flow, and some of them would have 2 or 3 days of like increased symptoms before they felt better.
Yeah.
And I knew I didn't miss anything in that neurovascular flow because I assessed it and reassessed it. So I'm like, okay, they're still clogging because I took all this deep stuff and it couldn't get out, and they could have some brainstem swelling symptoms for a day or two. Not a lot of people, but to me, that was a warning sign. There's something in this paradigm I'm missing. Going back into full workflow, I made the observation that this was the segments of the spine that attach to the dura, like the tailbone, the C1, the C2, the C7 through the nuchal ligament, and a lot of that bone torsion dysfunction that was essentially pulling down in almost a tethered cord, subclinical sense, the brain into the foramen magnum. So it was physically compressed. When I did all this drainage, it couldn't get out. So now I'm like, well, a lot of that's related to our osseous, to our bone periosteal dysfunction, treating the blood supply into bone, twists of bone, for those of you, I'm talking to counterstrainers, they know that. So I went back and said, now I got to say in bone class, all of these bones, super important because they attach to the dura. And in the dura class, all this dura, you got to check all the bones. And you better make sure you've done all these tests before you let that vascular concussion patient out the door. Because you may say, hey, everything's flowing, looks great in the lymphatic system of the brain, and they're still going to clog. So now I'm integrating, I'm teaching the classes very differently, because now I've been all the way up into the top, the central nervous system, and I can look back down and say, you know what, now that I know where we're going and what we're going to be doing, I got to emphasize some different stuff in this curriculum. I got to reorganize it. I may even have to add some techniques. So first thing is, if you took a class 5 years ago, it's already somewhat obsolete if you want to be an elite counterstrainer, right? So we allow auditing. Some people get to the point where you can be a teaching assistant. But the best people have, through Zoom audit, they've taken all the classes over again with more clinical experience, better hands. And then, okay, what do you guys always say to me? Wow, you really taught that different. Well, I tweak every class but the new one, the first one, because I'm teaching based on my paradigm as of that month. And when I prepare for that class that year, it is different from last year.
Yep.
So I think repetition. If you really want to be great, it takes repetition, particularly if it's a clinical pearl. You suddenly think about a patient. Oh my gosh, that would explain Mrs. Such and Such. Now you missed everything I just said. So a lot of times you take that class again, you're like, I don't remember him saying that. I don't remember, because you were processing. I can go down one of these rolls and throw a lot of fizz out fast. Slow talking. So anyway, the point being that nobody goes through this curriculum one time and is a master.
Yeah, 100%.
Okay. Also, do you have time to become a master? A lot of us have gone into longer cash sessions.
Yeah.
And the carryover is outstanding. People just need a matter of hours and it's done.
Yep.
So they're like, you're telling me I just need 3 1-hour sessions and it's going to work or not work? And I'm like, yeah. So I don't have to come 3 times a week for 6 weeks? No. Right? So, and then you can take your time and really go through the process, assess it, realize how efficient you can be.
Mm-hmm.
Okay. Like Willie Cherry, one of our top TAs, our head TA. Willie's, fantastic hands guy. And I don't know how, Willie's probably upper 60s now. He took the brain class and started taking some of the concepts that I went over in the first brain class and integrating all these other classes into the brain class. So now we're here, and here's what we did below to make sure this was safe. And it's like the process is so much faster now, right? Yeah. So this is not a stable curriculum yet. It will be in 3, 4, 5 years. And I'll be like, okay, it's where I want it. And I'm teaching other people to teach it now. So I don't have to, someday I could retire. But that's the first thing. Okay. Don't act like, well, I took it once, I should know it. No, you shouldn't know it in one time through, right? Give yourself, realize it takes real hands-on, real cases with real time to become an expert. You can't be doing 15-minute things and become an expert. There's no time to think and to work on it. You might have to get into a setting where you have time. Or if you're in a setting where they're making you see half-hour patients, maybe you take a few free patients on weekends where you have unlimited time to just practice the process to get good at it, right?
Yeah, we've done that in our practice here. When I was learning, I would say, I'm learning something new. Can I add 30 minutes of free treatment to your session? I would do what I knew to make them feel better, but then... Or I would reverse it. I would start with counterstrain and I would extend the time because it mattered to me to get good at this than to make the more money. Don't get me wrong. Let's go make money, but let's focus on the patient in front of us first, see what that looks like. I got to give a testimony to the curriculum changing so much. I took all the classes in 1 year and then took all the classes again the following year. And every time it was different. And I'm like, in my books, I'm like, how did he change that already? It is not stable. But in a
but let's not give the impression that I changed everything. I'm often changing on the impact of that technique. So I didn't change the technique, but now I know what it does. Mm-hmm. So we're talking about this full system approach, right? When you fix a spinous process dysfunction of C7, we say, okay, well, it's good for neck pain. No, it's pulling on the nuchal ligament. What is that doing up to the dura and higher in the chain? The first time I did that, presented it, I'm like, well, here's how you do those, and here's what they present like. But now I'm like, but in a couple of places, there's more power. Because I learned that through case studies. Does that make sense?
Yes, so it's and that's exactly what I mean by that. I'm thinking, it seems like the first class is like you're inundated with the information. And then the second class, you already have enough of a baseline understanding that it truly does feel like you're learning everything new.
People say the second time was better because everything's new. It's a lot to absorb. And since we're trying to teach the whole body, I'm always balancing. I want to get you guys through this stuff in a time and financially reasonable amount. I don't want to have 75 classes. But I don't want to throw so much in that you have to take every class twice or 3 times because there's too much material. Or you just get brain warped by day 3. So I'm always walking that line, 65 techniques. It's about all we can do. And then we start that class gets bigger. And then we have to eventually split it to a 1 and a 2 like nerve class. Make sure you have time to practice. Find some time that you can practice as long as you need to figure some things out, whether it's the last patient of the day. I did that last Thursday on an out-of-state patient. This guy wasn't where I wanted him by day 3, and he can't sleep, suicidal, migraine every day for 28 years. Cannot sleep. I did not have him where I wanted him by day 3. So I said, if it's not where you need to be by Thursday morning, call the front desk. I'll tack you on the end of the day, and I'll work on you till we figure it out. And I did. And it ended up being something I had never seen before. It was a deep hypothalamus thing that was getting him. He could not sleep. So I'm like, I need unlimited time because I'm doing something new here. And he's like, I'm there. I'm not flying Friday morning. I'll spend 7 hours. I literally charged him half hour, but I spent a lot of time with him because I was like, goal was to get you better by this third day. Come in a half hour, we'll treat you as long as you want. My wife's like, where are you? I'm like, had one of those cases. She's like, okay.
And that's what I meant by the women behind us being willing to sacrifice alongside you is so important. And here we are recording this after hours, after a long day in the clinic for the both of us. What we're doing here is we're actually trying to spread the word that, hey, look, there are good outcomes available to people. Again, counterstrain is not the answer to everything, and so we're not saying here like it's the only fix, and maybe that's a podcast for another time. So to getting close to wrapping up, counterstrainers are like, okay, that's what I needed to be excellent. Here's where we've been. This is where we are. Where do you see counterstrain going in the next 20, 30 years?
Yeah, I mean, extrapolating anything that far out with the way technology is changing,
10 years.
Let's talk maybe 5, but yeah, it's ramping up in its exposure, partially because we're allowing that. I didn't want this blowing up before curriculum is near the end, before we have some research that people can cite. Don't get the cart ahead of the horse again, proverbially. I wanted to make sure the curriculum is really, really solid. I have international presence. People can go and find us on the websites. I have really good TAs. I have other people teaching it. So the infrastructure had to be here. And then a couple citations like, oh, what is this? Read that. What are you releasing? Read that. So now I'm like, okay, I'm been saying yes to podcasts for the last 2 years because I'm like, now if you jumped in the curriculum, this thing is 90% of where I want it. And you went in 3 years ago. Like I said, we revamped virtually every class in the last 2 years and brought them up to where I now know we're going. So someone entering the curriculum today is getting a really, really nice model, 5 different assessments. The people today are so much better than people started 10 years ago. I mean, they can treat circles around them because it's just become the process and the workflow is that much more defined. I wanted it to be there before we get too much recognition. Do you have the capacity? If 200 people want to be in foundations next month, I used to fly around to each 20. Now we use the satellite model. We get someone like Dave in Florida. I got a group in Maryland. We got a group in San Diego. We're simulcasting with top-notch people on site. We're teaching 100 at a time. We're able to scale it. The classes, we did our first 3 series of foundations last year for the first time. 3 beginner classes, 5 satellites each. And the third group also basically filled. And that's the first time that's ever happened. The number of new students is really starting to blow up, which is the goal. We want more people doing this. Those of you who are interested in this are going to be in this field for a while. Something about technology that you really got to understand is when a disruptive new technology comes out that is a superior way, you got 2 choices. You learn it and you join it, or you become obsolete. You can't fight with an old paradigm something that's superior because people will choose the superior. You got to adapt or just get out. This is the next generation of manual therapy. So rather than be frustrated and use the old paradigm, get rid of the legacy, jump to the new. Okay. Yeah. It's worth your time. In 1, 2, 3 years, you'll be way ahead of where you were. And then you have this another 10-year tree of improvement where you'll be able to go all the way up and work on people that have inflammation in the brain, not just treating plantar fasciitis. Right?
And I'm just going back to my old model and I'm like, man, I couldn't imagine treating now the same way I used to. There's so many reasons why we need to make that switch. And
you did it. There's a natural resistance. There's a fear. There's like, gosh, I don't want to start over. Because it takes a lot of guts to say, I'm here and I'm pretty effective. But I'm going to step down in effect, become a novice again so I can go here. Not everyone's willing to make that jump.
It's hard to understand where people's mindsets are with that because I think you're right. It is difficult. I remember learning from people who are maybe not as credentialed as me, and I'm having to humble myself in front of these people that have been doing this for a while, that are your TAs, the ones that I look up to now. And I'm like, if I'm going to do this, I cannot come in here thinking I know anything. There has to be a humility in this in order to go low. God says that he'll support and raise up the humble and then strike down the proud. The reality is that pride is going to hold people back.
Pride or fear. Sometimes it's a fear of new. Everyone has a little bit of a fear of new. But I never enjoyed the job when I go in and the person says, I'm not any better. That's it, right? So it should drive you to be like, okay, what changes did you see? Not did it change at all. They'd be like, okay, you're going in with some confidence because you found it. You follow me? The process showed it matched their symptoms. You're like, so what changed? You can literally go in, they're like, well, this is better and this is different. Something happened. It's like, that's kind of your baseline now because you have this paradigm that you're looking at every system. On the flip side, I have people, I'm like, you know what? I don't see it. I want you to go get a medical workup.
Yeah.
It happens, right?
Yeah.
And they're like, well, what is it? I'm like, I can just tell you it's not dysfunction. There is, I got a guy came in with ALS 2 years ago, and it turns out it's a genetic version. He came in, weakness over his body, had visibly atrophied since last time I saw him. And I went through and looked at all the blood supply, spinal cord, everything, found nothing. And I said, this is not dysfunction. And he's like, what is it? I said, I don't know, but I want you to go to Hopkins and see a neurologist. But the absence of findings was a finding.
Brian, I want to thank you for your time. I think that you're going to speak, we're going to take this and really speak to a lot of people in this. Are there any things that you want to close us with? Any thoughts that you're like, I wish I had a chance to say that? Going through this process, where you started, where we are, where we're going.
Well, I would just say, first of all, that if you're a patient, you can go to counterstrain.com and there's a search for the practitioners on there. You have to take 4 classes before you're even on there. So I can help you try and find someone in your area. You may have to drive if you're a really complex patient. You can go to a higher level person. We just have people stay in a hotel and do a 3-day intensive. The practitioner lookup by state, by the United States, is most qualified at the top. So it is automatically organized that way. So that's, if you want to get some work, do that. The training, and you can put the links to
all the links to the counterstrain.com for the practitioner lookup, the Jones Institute,
which is the North American training. Yep, all there. And there's some links between counterstrain.com and the Jones Institute. Jones Institute, Dr. Jones, is the North American course group for people in the United States. So it's named after him. Point being, the first class is called Foundations of Fascial Counterstrain. If you want to train, you have to have a license to touch. So it's massage therapist or higher. You can't be a layperson and actually do this. We can't legally, liability-wise, teach you. But you could be a massage therapist and learn this. Many of them are PTs, OTs, osteopaths, chiros, acupuncturists, naturopathic physicians. One of my pediatrician patients was so enamored by the work that she closed her pediatrician practice, and she is a pediatric counterstrainer only. She only counterstrains, closed her entire practice. That's all she does. She submitted a case study on bedwetting, a case study on counterstrain for bedwetting, and she's going to try and publish it right now. So anyway, it's in many fields, but we're just trying to let people know if they want to get some training where they can go. It is international as well. We're in France. We're teaching a little bit in Italy, Germany. We're in Australia, and we'll start in Taiwan next year. Getting boots on the ground to train is always an issue. So you got to have practitioners first.
There's been multiple patients that become practitioners. They're like, what do I need to do? I've had several come through my clinic and have taken foundations already. It's mind-boggling that people are so moved by the technique that they're giving up careers in engineering and business to do this work. It's not just changing patients' lives. It's radically changing the trajectory of people's careers.
Who goes home every day? Can you honestly say that you change people's lives every day? I take that for granted, but when my one son was here and he was doing computer stuff before he moved out, and we would eat dinner together because he worked here for a year before he had enough money to move out. And he's like, how'd your day go, Dad? I'm like, I had a really cool case, and this person was able to do this and this. And he's like, great. You got somebody have a wheelchair, and I'm looking at numbers all day because my job sucks. But I said, son, you got to find something that you find rewarding. It's not just about money. You need to go to work and be like, I'm going to work because I love what I do. And when you can understand what your patients are going through and change lives, you will love what you do. And I don't know that someone like you or I, will you ever quit? I think we'd miss this interaction with patients. And can you take that kind of skill and just go play pickleball? I don't think so, right? I mean, so you know what you can, how much you can help you, but there's like a dopamine hit or it's a spiritual lift that you go home every day and be like, I just changed that person's life.
Yeah, it's funny. I've had business coaches literally speaking to me, Dave, you have to remove yourself from treatment to run the business. I'm like, you're assuming my goal here is to just run a massive business. That now, look, we can do a little bit of both, but the reality is that my goal here is to change lives, to get good outcomes, to actually impact lives for the betterment of not only the patient in front of me, but also their spiritual life. This is bigger than us, and it's bigger than Counterstrain. You already know that. We can look at the work. Counterstrain is one part of it, but the reality is that we are in the business of impacting lives. Counterstrain is one way. There is a spiritual health in another way.
You get to know the people and giving
yeah.
life advice, and
Is, you mentioned I impact these lives. We do company meetings on a regular basis, and we share wins. And we don't share wins because we want to look, Dr. Isaiah, look what he did. What we are doing, though, is we're sharing these testimonies with our office staff so they can join in, because I will tell you, and I know you rely on your staff as much as I do, the reality is that they are a part of that healing as much as we are. We do the clinical work, but the reality is the people that support us, our wives, our office staff, any other support staff we have, even the mentors in our past, Dr. Jones, and even your cohorts that trained with you, the reality is that everyone shares in this. And you may be the spear that's leading this charge for us in the Counterstrain world, but you're going to be passing the baton to the next generation. And then that generation is going to train the next generation. We're all going to be having a part of this. One thing that I believe very strongly is that God is not a single generation God. He looks at us from generation to generation. This is generational work. These are generational impacts in people's lives. And we can't look at this and be like, I'm going to build Renew or Counterstrain or any other business in that matter to be puffed up for the here and now. We need to have a generational vision for where this is going. And you've demonstrated that, because you're like, I don't want to get the cart before the horse, but I need to have the infrastructure ready to actually handle the influx of people as they learn about Counterstrain. And you've demonstrated that over and over again, year over year, while developing the classes, helping to raise up the next generation of people that are going to be training others in the future and now. And it's humbling, it's exciting to be a part of that process. I want to close us by saying all of the things we talked about, everything from where to find things, all the links will be in the bio, all of the citations for the nerds out there, for the clinicians out there that really need to understand this from a really nitty-gritty physiological level, it's there. It's not just about the testimonies, it's about doing the real science and the real studies to demonstrate the real effects of the body. And I want to close by saying, regardless of where you're at as a patient, there is a good outcome for you somewhere. Thanks for spending time with us, and have a good rest of your day.
If good outcomes matter to you, subscribe and follow wherever you're tuning in. If you're a new grad or a young clinician and you're frustrated with the system and its outcomes, go to renewintegrativept.com, click Join Our Team to learn more about our residency program. And remember, healing is possible.